Okay, so what we did with the computers, we just restarted the whole system, so it may have just been pulled from the weekend. Okay, let me go back and catch up with some of these. Where's the stuff? Okay, PCA pump, here is where the drug goes. It is put in a big syringe, and there's just a screw or a driver that pushes that in at the rate that you have programmed it in for. There's what the patient can hold and can dose themselves. This is where you can see readouts and what the patient is doing or has been doing. Okay, so here is an abuse deterrent. So you can see the original is up there at the top, and you can see they have mixed it with a liquid, and then they've drawn it up in a syringe. The reformulated tablet, that's the abuse deterrent, then they cannot get it to go into solution, so they cannot. It gets real viscous. This one does. It clumps too, so it makes it really difficult to snort or to inject. Questions about those? Okay, picking up with fentanyl. This is a synthetic opioid, so it's different from morphine, so a morphine derivative. Available in multiple dosage forms, so it makes it really easy to adapt to a patient need. Very potent. You'll see it's prescribed in micrograms instead of milligrams. It doesn't cross-react with morphine allergy because it's not a morphine derivative, so good to use as an alternative. Usually IV is reserved more for acute pain. You'll see down a few bullets that it says it's contraindicated in acute pain. It's not your go-to. It would be one that you would use if other agents were not available. It's very sedating, very easy to overdose, very easy to overdose kids. I'm not a PEDS PharmD, so I can't tell you exactly what they would do with this in children, but I would assume that it's not used very often at all because very small doses can be fatal to kids. Lollipops, lozenges, we've talked about. Those are often used in breakthrough in cancer pain. So they may be on a long-acting agent or a patch, and they use the lollipops as a way, or the lozenges, to address breakthrough pain. There's an immediate release transmucosal, so a buccal agent that can be used, just another one as a reminder. Nasal spray, sublingual spray. The patch, the Duragesic, has a very long duration of action. On an outpatient basis, the problem that I saw the most in patients on chronic opioids was this, the patch. Dosed way too high, the onset is slow, but the accumulation is great. So I saw a lot of older patients, not a lot, but I had significant, they stick out in my mind, getting in trouble with long duration of that fentanyl patch. So the advantages of the patch, to kind of keep it in mind, is if you have patients who have difficulty swallowing, let's say they've had radiation or they've got radiation mucositis, and so they can't get things down, or for other reasons that they can't swallow, the transdermal or even the transmucosal would be ones to keep in mind. If they have the itching secondary to the morphine, this is an alternative for you. It has no active metabolites, so it's one to keep in mind for renal insufficiency. Hydrocodone, drug of choice for selling. These, when these were more available, they were about $5 a tablet on the market, is what the patients would tell me. When I started as a pharmacist, this is Tylenol number 3, or not Tylenol number 3, Vicodin, Lortab, Lorcet, that's what would be this drug. When we went to unit dose, so used to, in a hospital pharmacy, it looked just like a community pharmacy. You had all these bulk bottles, you had to dispense each one individually for patients up on the floor. And then they went to, probably in the early 80s, we went to a unit dose system. So everything, the manufacturer unit dosed every product in a package that could be dispensed. I remember our director telling us that the amount of Tylenol #3 and Vicodins that he had to buy went down by 66%, just because of pilfering from the staff. So, I don't know, that little aside. Anyways, because of its propensity for abuse and resale, it was moved to a Schedule II. So that's a change in schedule several years ago. Usually available in combination with Tylenol or ibuprofen. In fact, I don't think it comes as a single ingredient at all. Again, a reminder, max dose is based on that non-opioid content. Place in therapy, so it's a good combination product, used probably more often on long-term basis, but also can be used in the short term. Oh, it does come as a solo. Tramadol, again, tramadol is an opioid and also monoamine neurotransmitter reuptake inhibitor. So it also affects norepinephrine and serotonin. So patients on serotonin products, also on MAOIs, if you're starting this, you'd have to be very careful. Incidence of gastric upset may be higher with tramadol. You've got those serotonin receptors in the gut, remember? So when we use those SSRIs, some of the side effects were diarrhea, constipation with others, so it's that serotonin effect. Seizures can be a problem with patients who are on antidepressants and neuroleptics, again, part of that serotonin syndrome. Higher increased risk of suicide with tramadol. Commonly used drug for chronic pain. Okay, next page, drugs to avoid. Meperidine and codeine as single entities. Meperidine, again, because of its side effect profile, makes it a more difficult to drug, especially in the elderly. Also, if you use an opioid agonist or antagonist on people who are chronically on opioids, you can cause a reversal or a decrease in their pain control. So just keep that one in mind. So if you're using an antagonist, you're going to antagonize the effects of the opioid. Let's say they come in the hospital using one type of product, you switch them to another, then you have the possibility of precipitating pain or loss of their pain control. Okay, that's just an overview of the products. Any questions or comments about those? Okay, let's move on to the adverse effects. So these you will see commonly. Constipation is probably one of the biggest problems to deal with. It's even now referred to as opioid-induced constipation, or OIC. It's very common. It's physiologically different from constipation. So you have opioid receptors in the gut. They respond to endogenous opioids, and they are part of the regulation of the peristalsis, transit time, the time that the material or fecal material is in contact with the intestinal wall to remove fluids, reabsorb. So they're really important. So when you knock those out, you change transit time. You slow it down, and you allow more time for the intestinal fluids to be reabsorbed. And so that's what leads to those very hard stools, possibility for fecal impaction, especially in the elderly, or people who are on other drugs that are slowing the gut down, which would be what kind of drugs? Drugs that have what kind of other pharmacologic properties would be additive to this? Anticholinergics. Okay, so other drugs have anticholinergic effects as well. So those will compound that. So if people are going to have to be on opioids long term, you want to start a bowel regimen to prevent constipation at the same time you start the opioid. So these would be people who are going to be on it for longer than 3 to 5 days. Or people at very high risk, debilitated, immobilized, Fluid intake is not always under their control. Those would be the folks who are going to be at most risk. So we have non-pharmacologic things we would initiate. So we want to keep them hydrated, want to keep them walking around if they can, want to keep their fiber intake up if that's appropriate. It may not be appropriate in all patients. So those kinds of lifestyle things we would want to encourage. Laxative therapy, there's two different kind of approaches. I would say Miralax, the second one, has probably overtaken it as more the drug of choice for opioid-induced constipation. So remember what type of laxative Miralax is? It's an osmotic, okay? Lactulose, very similar to Miralax, so you can use that as an alternative if you can't use the Miralax. You would dose it, you would start with 1 tablespoon, which is 17 grams, and advance it until you get the stool consistency or bowel movement that your goal is. The other, and this is kind of an older approach, is to use Senna, which is an irritant laxative, along with a stool softener. I'll tell you, for the most part, stool softeners don't work very well because people usually underdose them. This says 200 milligrams, they usually need 300 milligrams or more with a lot of water. So it just usually does not get the same effect. So this is, I would say, is a more ineffective or not as effective approach as the Miralax, and I think that's why it has now taken #1 place. If those interventions don't work, then you can look at the other pharmacologic drugs that have now come on the market. You hear the commercials all the time because I know you watch TV. So these are the ones, Relistor is, Amitiza is it's a non-opioid antagonist agent. It's the only one in that group. It's equally effective, orally active, so it is one that you can certainly choose. The opioid antagonists are much more common. There's more than 3. I just gave you the kind of the top 3. Relistor is the one that has been used the most. It's been around the longest, probably the best studied, but it's an injectable. The rest of these are oral agents, which may lead to its decline over time. The adverse effect is that you could reverse the pain control part of the opioid, so it's a delicate balance with those. Pay attention to constipation. It will not get better. Usually it gets worse. So remember that and start the preventative measures right away, and talk to the patients about what to expect and how to prevent. On page 10, there's just a chart there for you that I pulled out of one of the articles, just to give you some ways to look at advantages and disadvantages. Questions about the constipation? Itching, just a reminder again, this is due to histamine release, usually not allergy related. If you have to use the drug and you can't get around it, then you can use an antihistamine. So you can use hydroxyzine. Diphenhydramine is centrally acting, so it can make patients really sedated. And this will worsen constipation. So again, you just get into these fine balances with patients. Nausea is usually self-limiting. Patients usually may be nauseated in the beginning. That usually goes away fairly quickly. You can use antiemetics. Some of them, be wary, like with promethazine, you can significantly affect sedation or make them much more sedated. Sometimes opioid rotation will help with this if it's chronic and they can't seem to get away from the use of an antiemetic. Metoclopramide would be one to consider here because it doesn't affect, it's a prokinetic drug, so it doesn't cause constipation as much and it doesn't cause sedation. On the flip side, it can cause hallucinations. Especially if you've got renal impairment, you're using a higher dose, That's the flip side, especially in your elderly. Sedation, again, tolerance usually develops due to this, so it's one of those early on, like nausea, usually will go away with continued use. But warning patients, especially if you're sending them out the door, they're opioid naive. Maybe some of them would be told you shouldn't drive. They may go, yeah. But you need to reinforce that if you're using these medications, you don't need to operate something that requires extreme attention like driving. Cognitive effects, we talked to sleep disordered breathing is becoming more of an item that people are paying attention to, that these drugs change. So if you already have somebody who has disordered breathing, they have sleep apnea, this could be making it worse. So pay attention to those patients that may be more at risk for influencing their sleep. The last one is respiratory depression failure. We talked about this in the overdose situations. We're going to talk about now in the more therapeutic. We're going to go back over naloxone just to refresh your memory about that. Again, you've got opioid antagonists that can reverse the effects, and naloxone is your go-to. You now have what they call bystander rules, where patients can go, or people who are living with someone who is on an opioid or is an opioid abuser, they can go in and they can get naloxone. I'll show you how those products work. And then there are prescription products that you can also, so they can get it without a prescription, probably a cheaper route, and then there are prescription items as well. So the thing with naloxone, it can be given lots of different ways, routes of administration, which is good, especially for bystanders. We can teach them how to do an IM or an intramucosal or intranasal. Remembering that its duration of effect is very short, so it can be repeated quickly. You can't really overdose somebody on them, but if they are on a drug for pain control, you can certainly reverse the effects on pain. The other is that you need about 2 to 3 hours of not having to give any naloxone to call it good, to where you've got beyond those effects of the opioid. Next page, who's at risk? If they're on very high doses, which your cancer patients could certainly be on, those who have lung disease, because of the effects, they're more likely to suffer from respiratory depression. Kidney disease, liver disease, those would go to drugs that are metabolized and then renally excreted that have active metabolites, because you get prolonged pharmacologic effect. If you're mixing them with other CNS depressants, so what would those be? What would be other common CNS depressants that somebody taking chronic pain medicine might be on? Benzos. What else? Self-administered. Antihistamines, the generation 1, first generation, alcohol. Bad combo. If they're using opioids recreationally, which means they're using probably higher doses, or they could be using like the fentanyl laced ones that we talked about, that are laced with heroin, and they're not regulated by anybody but the drug creators. Those that have bipolar disease or schizophrenia, so you're looking more at judgment in terms of the ability to use a drug appropriately, especially if they're not well controlled. Okay, so we talked about providing opioid antagonists to family members. So that might be something you have a conversation with people either on an outpatient basis, maybe not so much on an inpatient basis unless they came in an overdose situation or overly medicated situation. So talking to them about keeping it in the house or with them would be important. So let's look at the different products. So naloxone is, and here a pharmacist can help you. They can help the patient, they can help you in advising about which way to go. So it's available for a vial for injection. You also have pre-filled syringes. You have prescription items. You have a Narcan, which is a nasal spray, and you have Evizio, which is a pre-filled auto-injection. I'm going to go through each of those. So this is a little bit different. You know my diatribe on people using epinephrine for substitutes for EpiPen. This is a little bit different in that these have been more worked out. There are ways to train patients, and there's also items that patients can get that will help them safely administer. Not patients, but their family members. Okay. So you have the injectable products, you have the pre-filled syringes that patients could use. Pharmacists can teach them how, or you can teach them how to give an IM injection. If they're using that pre-filled syringe, they don't have to draw anything up, they don't have to mix anything, you can teach them how to do that. If they're using a vial, then they would have to have syringes, and they would have to have needles. So thinking in advance about what you would have to, what other equipment they would have to deliver if you're not using a ready-made product. There is, if you look on page 12, a lot of different community action groups have come up with this approach. And I think it's good as long as the patients are trained. So this little thing is called mucosal atomizer device, this little cap here. So this, if you look on the next page, kind of keep those two pages together, you can kind of see where they're going with this. So this is a syringe. This piece right here is called a Lurlock. So a Lurlock, we use those a lot in the hospital whenever we're wanting to adapt a syringe or a barrel of the syringe to do something or to attach to something other than a needle. We'll use what we call a Lurlock. Fits onto the hub of the syringe right here. So that's the Lurlock. If you look at the next page, let's see if I got that. So several different ways you can go here. So you can buy, this is the naloxone, this is how it comes. If you look down on the next page, let's see. So it comes in this form. You can buy a syringe in which you can, similar to like you have with when you're drawing blood. You know, they pop those containers into a what do you call that thing that sits on top, the vacuum container? That's what they draw it into. But what's the other thing that they pop it into?
There's usually the deal that you screw onto it. I mean,
Right, that's what this is. So this is it's just an open barrel. This has a latex top in it. This has a needle. So when they pop that vial in there, it will pierce that. It's already connected to that MAD device, which is the Lurlock, and then this mucosal adapter. So when they put that all together, they can inject it very easily. Or, I'm sorry, they can use it to put it into the nose. So just going through that again. So this is that, here's the naloxone, there's the latex top. You put it in here and then you attach that Lurlock to the hub of the syringe with that mucosal adapter, and then they squirt a mil into each side of the nose. So that's something a patient could do. They could also draw up out of a naloxone vial into a syringe, take the needle off, put the Lurlock and the mucosal adapter on there and also give it. So those require training, but they're cheap. So this would be somewhere in the range of about $15 to $40 for a patient or a provider, family member to get. Okay. Are you following? There's lots of community action groups. I don't know that there's one in Oklahoma, but there's a project called the Lazarus Project. They put together these packs and will dispense them, give them out through different community clinics, especially where there's maybe a high addiction population or patients who use a lot of these products. When you use, if you're going to suggest this to a patient, that you use a higher dose with the intranasal, so that comes as a 2 milligram per 2 ml, that's what you use for the intramucosal. If you're using it as an injection, you go with the lower dose, the 0.4 milligrams per mil, and then they can re-administer the dose according to your instructions. Okay, if you go to page 14, that's where I've got the doses listed out there. $17 for a naloxone vial, $40 for the pre-filled syringe, so if you're going to teach them how to do an IM. And then the MAD device costs about $5. It's made by different groups. Some of them have been recalled recently, but there are still those that are available on the market for patients to get. They all require training. So if you're going to send them to a pharmacy, Walgreens. Does Walgreens do this? Have you ever seen them train? So they will. Does the person just have to request it? How have you seen that happen?
I've only seen it done once, and only certain pharmacists will do it. One pharmacist didn't feel comfortable having the education to do it. So I've only seen my pharmacy manager do it once.
There's another clinic. Scott Schaefer told you about it when he came to talk to you about the Poison Center. And they have pharmacists at that clinic that will also hand these out and instruct the patient. So that's one thing I would keep in mind is follow through and make sure that training is available wherever you are sending them. Evzio is a pre-filled auto-injection device. Okay, this is a prescription device. And the concept, I think, is really good. The price is ridiculous. The price is about $4,200 to $4,500 per kit. So it's just like the EpiPen. Because of demand, it has escalated the price. I think when they first came out, they were about the $600 range. So here's what they've got, though. Their technology is a little bit higher. So this was developed for use in the community. This is one of the dosage strength. It comes with what they call a trainer. So the trainer, and they recommend that people who are in situations where they may have to give naloxone on a more frequent basis, maybe several times a year, that they refresh and train, just like we do with the EpiPen. We can give trainers with the EpiPen and advise parents that they need to refresh their memory about how to do this. So it comes with a trainer, and that trainer can be used up to 1,000 times. So it's very durable, doesn't contain any drug in it. So it can be used to train people. Then it comes with an active drug, and there's 2 syringes, or 2 doses in this. The thing that makes it so different is that it has audible instructions. So once you activate the product, it will walk you through how to do it. It only comes in English as far as I could figure out at this point. So that's the good side. The downside is the cost. But it does have a higher degree of technology. I don't know where these would land. I don't know exactly who. I looked at different insurance companies. Some insurance companies will pay them full out with no copay. They do have, like the EpiPen manufacturer, they do have the ability for patients to request the drug if they have no other way of payment, and they can get it for without cost to them. There are coupons on the internet which are for about $1,000. So if you go in, you can purchase it for $3,500 instead of $4,500. So there's all different ways. So I would say there is no blocked access. You might have to be persistent in how you get it if this is the product that you think is right for the patient. So again, 2 different strengths. It is a direct delivery. So you would fax a prescription to the company. They will direct deliver it to the patient. So it doesn't go through a pharmacy. Questions about those? There are several, if you're curious about them, there's several YouTubes where you can actually hear the the voice guide. The other one that's on the market is the Narcan nasal spray. It's much less expensive. It's $150. It's already ready to go. Comes as 2 doses in together is what they get. So it's a relatively inexpensive. No, there's nothing the person has to do except know how to administer it. It's pretty easy. The other pertinent things you need to remember to tell people is that if they suspect an opioid overdose or oversedation, give the drug first, then call 911. Okay. So that there's no time delay. And again, counseling people also provider or patient or family members that are going to use it that they can cause the withdrawal from the drug, so they can then experience opioid withdrawal. All right. Questions, comments? Okay. Drug interactions. Biggest thing to keep in mind with opioids is look for other CNS depressing drugs on their regimen. Okay. So if you're seeing them in an outpatient basis, and you've got family members there querying them about that, that's where I have seen the most problems in outpatient, is dealing with that oversedation or just their general change in mental acuity that the family members will often complain about. So CNS depressants. Analgesics, keep in mind that the use of Tylenol and the nonsteroidals, keep in mind that max a dose amount of acetaminophen, which is what?
4 grams.
How much is a daily amount?
4 grams.
3 to 4 grams per day, or if you've got somebody who's in relatively good health, 3 if you've got alcohol drinker or someone who has impaired liver. Nonsteroidals, keep in mind your renal effects in especially your elderly. Always look for multiple sources of these drugs. I'm telling you, patients won't know that. And they'll use products with multiple Tylenol, multiple nonsteroidals in them and not be aware of it. So always have a high suspicion for that and ask so that you can figure out if there's multiple sources there. Other adjuncts that we've talked about in the past, just to remind you, would be gabapentin, good for neuropathic pain. Okay. The bisphosphonates, if you have bone pain, then using the bisphosphonates to strengthen the skeleton. The other would be the lidocaine patch, or topical, also for nerve pain will help. Okay, any questions? All right, I'll see you Friday.